Thank you. So, thank you for the kind introduction. So, I'm going to be presenting on systemic lupus erythematosus, congenital heart block complex. But in as much as I have titled this presentation, I just want you to take this as a case of fetal bradycardia antenatally. When you see a patient who comes in with fetal bradycardia antenatally, when it's not because of fetal distress, of course, which you always see in the labor ward, okay. So, congenital atrioventricular block affects 1 in 15,000 to 1 in 20,000 live births globally, and it presents, like I've already alluded to, as fetal bradycardia as a result of these various degrees of heart block, which can be first, second, or third. So it may be caused by a variety of conditions, such as autoimmune conditions. We have SLE, we have Sjogren syndrome, structural defects, maybe severe atrioventricular defects or even atrioseptal defects. We can also have torches, among others, which can cause carditis and then present with heart block. So the commonest cause globally is actually autoimmune antibodies from SLE, Sjogren syndrome, and other rheumatoid diseases. So this is because in these conditions there is placental transfer of maternal antibodies, which will then cause damage and fibrosis to the fetal conduction system. So this may result in in utero fetal demise, or even after delivery it can cause long-term cardiac morbidity in the newborn or neonatal death. So in this case, I'm going to present a case of congenital fetal heart block, which would then made an impression that it was as a result of SLE. So I'm presenting Miss JC. So she was 31 years. She's 31 years old. She was in a third pregnancy, para 1 plus 1, and now gravid 3. So she came at 31 weeks of gestation. She's been dated by dates. So she came as a referral from a local clinic because they had picked up fetal bradycardia. So there's also the fetal heart. When they did their ultrasound scan, they did an ultrasound scan, it noted a fetal heart that was way below 100, and they also knew that there was a mild polydramnus, and referred to Salem Kabe Hospital FMU clinic. But the mother was otherwise asymptomatic. Patient was specific normal fetal movements. The current pregnancy had been booked at 14 weeks, 2 ANC visits, which were unremarkable. HIV and RPR were negative. She did not have any chronic illnesses, or was she taking any medications that could explain the fetal bradycardia. The social history was unremarkable. So when she came in, what is significant is that she was a well-nourished mother. There was no stigmata of SLE on clinical examination of the mother. Then, but when they tried to listen, midwives tried to listen to the fetal heart, they could not pick up the fetal heart, which can be explained by the fact that when you severe bradycardia, it's very difficult to then separate the fetal heart from the maternal pulse. So they couldn't pick the fetal heart on examination. So the ultrasound scan was then done in the fetal maternal unit, which showed a single intrauterine fetus with a weight of 1,155 grams, and the heart structurally looked normal. That's also an important thing to note in this presentation. But there were some ectopic beats which can happen even in normal pregnancies. And of note is that there was a heart rate of around 75 beats per minute, which confirmed which made the impression of the heart block. There was no pericardial effusion, and there was a mildly elevated peak systolic velocity in the midcerebral artery, which was already discussed in the presentation, could suggest fetal anemia. There were active baby movements. I think everyone in this place is familiar, at least, with this pulse of Doppler of the fetal heart, where we are seeing what I want you to see in this image is how there were very few pulses there. Okay, and the fetal heart rate in this particular image was 75 beats per minute, and you can also see that we do have some ectopic beats. That was one of which seems to also sort of to reset the heartbeat. Then in this image, this is the umbilical artery Doppler. So you can see again very few pulses, and you can see that in the middle there, you can see that the end diastolic volume is going was down, which resulted in raised pulsatility index. And again, I'll just refer to one of the questions that was asked to Dr. Verenga about very low PI. So this case had a high PI, but when you have a pump failure, sometimes you may actually see that they will behave the abnormal low PI that Dr. Verenga was referring to. So what were our differentials in this problem? Could this be autoimmune condition? Was this SLE? Was this Sjogren? Could this be in utero myocarditis, maybe parvovirus, maybe Torch's infection, or channelopathies, which could be causing, which can present as a second degree heart block, or could they be very big? So if in the region of the septum where there is the AV node and where you have the band of Rees, if there is a big septal defect there, you can also present with, the patient can also present with a fetal bradycardia. So we have to do a series of investigation to rule out our differentials. OGTT was normal, UNT, FPC normal, the torches were unremarkable, okay? Then, if not, our antibodies were the ones that were the problem. So the ANA was positive. Then we did anti-RO, anti-Robert, anti-RO, which was positive, anti-LA, which was also positive. Unfortunately, the patient didn't have funds for other investigation, which we would have wanted in a patient that you are suspecting SLE. So we didn't have funds for anti-double stranded, anti-Smith, and could also not do the antiphospholipid panel. So what was our clinical impression? Our clinical impression was SLE. Of course, the antibodies can also present typically in Sjogren. They can also be the same pattern, but because we know that heart block in the setting of pregnancy is usually because of SLE, we decided to make a clinical impression of SLE given the financial limitation. So the patient was supposed to be booked for a detailed fetal echo, which confirmed that there were no structural abnormalities and also confirmed the the congenital heart block. Then we consulted the mother about the condition. There was prescribed salbutamol. Patient was also prescribed dexamethasone or tevitrolene, but again she did not have funds for this, so she ended up receiving prednisone, which I'll explain later. So efficient assessment, which is very important, was ordered for the mother to be assessed for any organ damage in the setting of SLE. Then an MDT was planned with the pediatric cardiologist. So the first MDT, there was concern for worsening fetal bradycardia, and the recommendation after the discussion was that we could do expectant management. The FMU patient was supposed to be coming for serial ultrasound scans, then to organize a cesarean section at least by a registrar at term. So the patient had a C-section at term, and a live baby was delivered. Fetal weight was 2,550 grams. APGAR scores was 7, 10, 8, and 10, with a heart rate of 33 to 38 beats per minute. So patient was admitted to neonatal intensive care unit for supportive care. Okay, unfortunately there were no funds for pacemaker insertion. I think I had skipped that during as I was trying to rush. But this patient during the MDT, the decision was that there was nothing that could be done in utero. So the patient was supposed to get a pacemaker soon after delivery. What could only be done in utero was to serially monitor the patient. Okay, then soon after delivery, they were supposed to put a pacemaker so that you can boost a heart rate. But unfortunately, there were no funds. So day 2 post-delivery, the patient started worsening. Another MDT was done. What can we do about this patient? Unfortunately, there were no funds. So the plan was to try to seek alternative other methods to try to obtain the pacemaker, but it would have taken at least a month to get the pacemaker using, other pro bono routes. But unfortunately, the baby deceased 2 weeks post-delivery, awaiting the pacemaker. So if ever you remember anything from my presentation, please remember this slide. So it just shows you that if a patient comes with fetal bradycardia, okay, heart rate below 110, what is the general approach? Okay, so first of all, this patient has to be referred to a fetal FMU clinic. Why? Because they have to sort of make a diagnosis of what's causing that bradycardia. Is the heart structurally normal? And if you cannot carry out a proper ultrasound scan to determine the normal anatomy of that heart child, then it means that you can't probably diagnose the heart block. What is causing it? Because if you know what's causing it, then you can then plan who is going to manage this patient post-delivery, or are there anything that can be done once the patient is in utero. Okay, so during a fetal echo, that's when the heart block can be diagnosed. And if the heart is structurally normal, then possibly a differential diagnosis, you are going towards structurally abnormal, then probably that's where you then see the severe septal defect that I was talking about, etc. Then if the heart is structurally normal, that's when you need to now rule out other causes like the autoimmune or maybe the cause of myocarditis like the torches, etc. Okay, so you can then do maternal serology testing and raw antler if they are normal. Okay, we are considering the torches, etc. So remember this flow diagram. Okay, in our case, we made an impression of SLE congenital heart block, which is due to placenta transfer of antero and antler antibodies. So what do? They damage the AV node and surrounding tissue, causing fibrosis in that area. And the challenge is that often the fibrosis will cause an irreversible third-degree heart block. So most of the times, those steroids, etc., that can be given will not be able to reverse the heart block. But because of concern that the low pulse rate, the pump failure may cause high drops or even intrauterine fetal death. People have explored salbutamol, etc., and they may improve. Though to be honest, there's still debate on the best treatment method, and the best treatment method for an approach for the patient can only be discussed through a multidisciplinary meeting. Okay. So in conclusion, congenital heart block is an uncommon but a serious complication which we can encounter in our setup. A clear approach should be followed for proper diagnosis and treatment. Early multidisciplinary management may improve outcomes for both the mother and the fetus, more so in the absence of financial limitations. In SLE, when there is heart block, it is often irreversible and results in significant neonatal morbidity and mortality unless a cardiac pacemaker is inserted postnatally. I thank you.